Welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery 5.21.1 upgrade webinar for today, Wednesday, March 24th, 2021. Hope you guys are all having a good day. Just our agenda real quick. I'll just introduce everyone on the call. Let's see here. From STS, we have myself, we have Carol Crone, our Senior Clinical Manager of the databases. Let's see, we also have Dr. Wormuth on for our surgeon leadership today. From the core group, we have Katie joining us. We appreciate you joining us today, Katie. And then from our QVIA team, we've got Joe, Melanie, and Steve. So thank you everyone for joining the call today. As you all are aware, just the call overview. Again, this call is to continue our walkthrough of the 5.21.1 data collection form for the upgrade that's set to go live July of this year. I believe last time we stopped with the tracheal resection, section I of the data collection form. And again, I just wanted to apologize real quick for having to jump off the call rather abruptly last month. Thank you everyone for your emails and your well wishes. I do appreciate that, and thank you for checking in, but all is well. So with that, I'm going to turn things over to Carol here in just a second. I just wanted to point out the draft data collection form has been updated. I updated that on the 4th. Just a few minor updates, nothing variable wise, just corrected a few spelling issues, added a section header here and there. So if you wanted to download an updated draft copy, that was again posted on March the 4th. With that, I'm going to go ahead and turn things over to Carol so she can go ahead and kick off the call. Thank you, Carol.
Thank you, Leanne. Hi, everybody. And thank you for Dr. Wormuth for joining, and thank you for Katie for being on with us. And I'm going to get started here. So this is just a quick reminder of something we went over on our last call in February. The ECOG will only be required on analyzed cases. It will show up on your missing variable report. You can filter it out. All other required blue underlined fields will be required on all cases that you enter into the database. And then next slide, Leanne. Procedure weighting, we talked about this last time. Just a quick reminder that it's going to be high score wins. So when you code your procedures, this is going to help you indicate what should be coded as the primary procedure. Each procedure listed in the section will have a weight with that section. And the task force had consensus that the biggest procedure performed is an esophagectomy. So the esophagus cases are ranked the highest, and this will provide some clarity in the training manual, but this is to help code the correct primary procedure. And we'll also have this fire some flags in the IQVIA platform for when you upload the data into the warehouse. Next slide, please. All right, and two clarifications that came up on questions last month on the call. The first was related to this 32674 and this previous 38746. 32674 should have been removed from this version. It was not. It will be removed in the next version. If you code it or not, it's fine. The consensus from the surgeons was that lymphadenectomies are captured in the node section, so we do not need to double capture it here in this section. So it will be removed in the next version. Next slide is the robotic sequence 1400 and the robotic assisted surgery S2 900. This robotic assisted by robotic technology is under the operative section, and the robotic assisted surgery we added as an additional procedure code S2 900. Both are DB coded for robotic surgeries. And that will be included in the training manual. That's what I had for updates, and now I'm going to share my screen if that's okay, Leanne. Okay.
Yep. Sorry, I was muted. Thanks, Carol.
That's all right. So we'll walk over this, and thanks for Melissa for joining us on the panelist side. So we'll get started here in the tracheal section. Does anybody need extra time to pull up their data collection forms? If so, just let's see. I don't know if we have the I raised my hand. I love it. Oh my word. Where did my thing go here?
I can lower your hand, Carol, if you like.
Yeah, that would be good. Thanks.
There you go.
Thank you. I'll just give folks a few seconds here to pull up the form and we'll get started. The tracheal resection is about halfway through under the operative, specific operative sections. The form on the left with the yellow highlights is the very draft, all changed document. The form on the right is the clean DCF. We didn't have a whole lot of changes within this section. Probably the biggest thing is that we went from all of the 5 questions down to 1 question where you could select all. Again, you can map this if you're pulling data out at your hospitals by using the harvest codes instead of the previous short names. And the same thing, we did that for airway management during resection, and same thing with incision. We changed the length of tracheal resection from millimeters to centimeters. And we added in this suprathyroid hilar option under the release maneuvers. But no real main changes here. I guess we did provide a little bit of clarity here regarding the stent tube free at 30 days. On just yes, no, or patient died within 30 days. And then if no, was the patient stent tube free at 90 days. Similar parent-child relationships, but no major changes. Dr. Wormuth, do you have anything to add to the tracheal section that maybe I've missed or you'd like to provide more clarity on?
Nope. Just interested to see what the data looks like when we had it at millimeters and limited to 10, and which is way too short.
Yeah. So hopefully centimeters, hopefully we have it correct now. Well, we do have it correct now, but hopefully it wasn't too bad previously. The next one is hiatal hernia GERD. And I looked through this too. I didn't see too many significant changes other than we went from the multiple questions down to the 1 question with the select all options. And then for Barrett's esophagus, we added in intermediate indeterminate for dysplasia and without dysplasia as grades. So you have those grades to choose from. And the EGD done as a parent to the esophagitis, esophagitis and the Barrett's metaplasia, and then the LA grade and the Barrett metaplasia grade. No major other changes there. We got rid of the hiatal hernia size, corrected some spelling, I guess. Procedure approach, the group went from the 4 questions to a select all that apply and added in the robotic abdomen, clarified this is robotic chest, and then added in an option for robotic abdomen. And then we also added in an option to describe Link's procedure being performed. And then I'm trying to see. And I'll get Nancy, I see your questions coming, but we'll get to them in just a second after we finish the review. I think we can get through the rest of the form today. So we'll get to questions shortly here. We're still in the hiatal hernia section. This is the patient alive at 30 days and then 1 year post-op, and just changed them to select all that apply. Disposition, we've gotten rid of that. If you'd still like, there was some discussion among the core group members and the surgeons regarding patient disposition, if they were discharged, if they were discharged from the OR to ICU, and if they were their times, we've removed that. The decision was to remove that. However, if you would still like to collect this data, you could have your vendor add in site-specific fields to capture it just within your own hospital system. If you're a direct data entry participant, IQVIA has the option to add in a minimal number of data points, and you could use that option to add these in to still collect those at the local level. Post-op section, we've had some major changes here, and I'll let Dr. Wormuth take this over. We tried to align with the ESOS database, and I forget the initial CTCAE, I think, or something, Dr. Wormuth.
Yeah, so the
definition.
CTCAE is an oncology grading system for the severity of complications, and mostly applies to sort of chemotherapy, radiation therapy problems, but actually overlaps somewhat very nicely with our complications that we ask about. And so we took a subset of severe complications for our database and asked, if possible, to get a grading of the severity. And we specifically took stuff that was didn't seem applicable, didn't seem like we needed that information, or the scoring system didn't seem appropriate, and did not ask those questions. So although it looks like we are asking a whole lot of new questions, trust me, we wiped out probably 2/3 of the questions that some people wanted to ask. So one particular thing that we did was, there was this on the old form, did the patient have an unanticipated post-op invasive procedure, and that was frustratingly vague, and we kind of tried to focus it just on a few things, and decided we didn't like that. So now the question is, did the patient have another operation through a new or existing incision? Yes or no? And because of the NQF, we needed to ask if you said yes to that, was it due to bleeding? Because we need that particular fact for the NIPS and NQF measures. Then we got rid of those categories, and we just started asking specific questions of the different sections. So for pulmonary, did they have the air leak greater than 5 days? Yes or no? Did they get a therapeutic bronchoscopy? So our intention here is that the bronchoscopy was done with the not just to look at, say, an anastomosis, but to troubleshoot a problem at the anastomosis, to dilate it, to stent it, to remove secretions. Some form of active therapy is done with bronchoscopy. Whether or not they had a pleural effusion requiring drainage, yes or no. So the first grading complication we get into is pneumonia, yes or no. And if you say yes, then we ask you for the grade. And grade 2, you can read the definitions there, but basically moderate symptoms. Grade 3, an invasive intervention was required, IV antibiotics. Grade 4, life-threatening complications, like they had to be intubated, a marked negative turn from the pneumonia, not just incidental, but it altered the course of the treatment. And then 5, if you know that they died from pneumonia, please just tell us 5. We don't have any way of knowing what the truth is between grade 4 and grade 5. So there was a lot of discussion to leave grade 5 off. We wanted to leave it in because it's part of the coding system. And sometimes I had a patient that post-op developed pancreatitis from a lobectomy. They were a chronic pancreatitis. They developed a pulmonary embolism, and an hour after they developed the pulmonary embolism, they died from massive heart failure. So I know that his death, even though he had other complications, is due to his pulmonary embolism. Sometimes it's that clear cut, sometimes it's not. And if it's not, just give us your best. Grade 4s, we'll take that. So moving on, after pneumonia, we've got adult respiratory distress system, yes or no. And then again, looking at the grades there. So if we don't have a grade, like there's no grade 2 for ARDS, it's because the code for 2 wasn't appropriate. It was, before you get an ARDS and the CTCAA, and we just didn't put that there as a choice, because by the time you have ARDS, you're either grade 3, grade 4, or grade 5 for us. Respiratory failures, just yes or no, and that just means that they basically needed to go back on the vent or high flow or BiPAP or something like that for a significant event. Whether or not they developed a bronchopleural fistula, here we have pulmonary embolism, yes, no, and again, for my patient that I talked about, I would say that his grade was 5 because that's the event that took him out. Pneumothorax requiring chest tube reinsertion, initial ventilatory support greater than 48 hours, whether or not a tracheostomy was placed. And then atrial arrhythmia, this is another one. It does have CTCA grading, but we were so far beyond what they were asking that we just want to know if they went home on some form of anticoagulation specific because of the atrial arrhythmia. So Coumadin or Eliquis, Xarelto, whatever drug might have been picked. Ventricular arrhythmia requiring treatment. Again, I think the atrial and arrhythmia are a little bit different than they were before. Just we're really trying to get people that are new into those events. If they came in AFib and they went home in AFib, that's not a post-op complication. We wouldn't expect you to tell us yes if it's not new onset atrial arrhythmia.
Yeah, that previously on Dr. Wormuth, on those atrial and ventricular arrhythmias, we had the language requiring treatment and we removed that language.
Yeah, thanks.
Okay.
Well, we still have it on ventricular arrhythmia requiring treatment.
I'm sorry, under atrial.
Atrial arrhythmia. So the treatment that we were looking for there was, did they have to go home on some sort of blood thinner? Myocardial infarction, again, adding in the grades. So Carol, your right-handed screen, I think, is not the oldest data form. It's not the original data form, right? That's the 241 that you've marked up.
The one on the right.
Like we didn't have. Sorry, one on the left. I don't know left and right.
The one
on the left.
Yeah, the one on the left is the very draft form that we used for the upgrade calls. It's not perfect.
Yeah, right. No, but in terms of, because I think there were some different parents in the GI section as well, but that's okay. People probably figured that out. Deep venous thrombosis, whether or not, so then GI, did they have an ileus? For esophagectomy, did they have, and this is new, this is some of the ESO data. So this group that tries to track complications after esophagectomies. And we looked at their definitions and then adopted some of them. And so this is different from what you've seen before. Kind of goes hand in hand with how we're doing the different procedure collection. So we wanted about delayed content emptying requiring an intervention, either dilating the pylorus or injecting Botox, maintenance of an NG drain more than 7 days post-op. Those are events where we would expect you to say yes if there was some sort of delayed emptying. And then whether or not there was an esophagogastric leak from the anastomosis, staple line, or localized conduit necrosis, yes or no. And again, we've applied 3 types here. Type 1 is just a little local defect with no change in therapy, treated medically or with dietary modification. Type 2, localized defect requiring intervention. So basically putting in a stent or a drain, a pigtail drain, that would be some sort of intervention. And then type 3 is a localized defect that needed to go back to the operating room for basically a reopening of the incision or a new incision to address a complication. That's what we mean by surgical therapy. If a surgeon is doing the stent placement, that's not surgical therapy, that's an intervention, but not an incision. And then if there's conduit necrosis or failure, and then again, type 1, type 2, or type 3, endoscopic, additional monitoring, but no surgical therapy required. Type 2, identified endoscopically, no free anastomotic or conduit leak, surgical therapy without esophageal diversion. Or type 3, extensive necrosis, and that's where you have to go take the stomach out, put whatever's live back below the diaphragm, bring the esophagus out on the chest wall. That's a disaster when it happens. It's rare, but it does. But that would be the type 3. And I think the packed red blood cells is pretty much the same. urology, urinary tract infection, yes, no, and whether or not a catheter had to go in and did they go home with a catheter. And then for infection, this one's also different. Empyema requiring treatment, surgical site infection, superficial, deep, or organ space, whether or not sepsis was involved. And we kind of pulled these, I believe we pulled these from other areas to kind of coalesce so it made more sense. And then other infection requiring IV antibiotics. For instance, they got a gangrenous foot and you're treating that. So they're getting antibiotics, but it's not for pneumonia. And then neurology, new central neurologic event. Yes, no, and then details of the type. Was it just TIA? Was it a RIND, which is a 3-day event, or was it longer than 3 days, 72 hours? Or was there an anoxic or metabolic encephalopathy, thrombotic event? And then recurrent laryngeal nerve paresis that's new, and whether or not it's unilateral or bilateral, and then what needed to happen to help the patient with that. Is it just medical or dietary modifications, so thicken liquids? Did they get an elective injection of silicone, or did something emergently have to happen, like a tracheostomy? Whether or not delirium was there, renal failure, we're using the rifle criteria, and whether or not they were discharged newly on dialysis. An unexpected escalation of care, meaning that wherever they were, step down unit or floor, do they have to go, to the ICU or to the step down unit from the floor? We're trying to just capture that. And this is a hard question for us because different sites use different criteria. One hospital pre-COVID, everybody went to the ICU. That's just where they went. There was no step down unit. Post-COVID, when there was no ICU beds, we learned that they could just go to the floor. And so, it looks like if someone was looking at our practice, we stopped using the ICU. That's what we did, but it's just our local culture, and we get it that other hospitals do things other ways. That's partially why we didn't try to define where the treatments happened. We used to talk about, was it in the endoscopy suite? Was it in the operating room? And again, there's so much variation in how surgeons feel comfortable doing things. It doesn't mean anything if surgeon X does it in the endoscopy suite and surgeon Y does it in the operating room. You can't compare them one to the other. So getting back to the last little bit that's different, chyle leak. We had several questions in the old form that tried to get to address whether or not there was chyle and how it was handled. And this again is scoped on the esodata.org stuff. So was there a chyle leak, yes or no? If there is, then we're looking here for the peak output. So was it less than 1 liter per day maximum, or was it greater than or equal to 1 liter per day maximum? And then a grade of how it was treated. And did we just do like branched chain amino acids? Did they put them on TPN? Or there was some other type of treatment? And if there was treatment, was it surgical or IR? And you can do both. And if you did it, which one worked? So that's what we're trying to capture with those chylothorax questions. And then discharge mortality. I'm letting you have this one, Carol.
Thank you. Thanks, Dr. Wormuth. That was a great overview of the major changes. I think those were the biggest changes for the general thoracic for this new version. For discharge mortality, we're going to ask first if the patient's still in the hospital. If they are, then you don't answer these questions. This can also be used as kind of a placeholder for when you submit your data to the warehouse. If you still have a patient in the hospital, say for a rather long time, that falls into the harvest window, or falls into the harvest period, and the harvest closes and they're still in the hospital, analysis will look at this and pull that case out. I think that will occur at DCRI, so it probably will still show up in your raw unanalyzed data on the IQVIA dashboard, but it should not go into your analysis data at DCRI. If they are not still in the hospital, then the hospital discharge date and then the status at hospital discharge date. It's important to know that patients who are discharged to hospice will be considered an operative mortality, regardless of when they die. So if you have and we'll provide education in the training manual, this is a change that the surgeon leadership felt strongly to include these hospice discharged patients as operative mortalities. The discharge location you'll provide for patients who are discharged alive, last known status alive, or discharged alive, died after discharge. And then the question with chest tube HOMO 2 at 30 days, and then readmit to any hospital within 30 days of discharge. The substance use and screening counseling performed is a NQF measure that was added earlier this year, and we'll provide clarity on this. It's an all or none type of question. The question's asking if you provided counseling on tobacco cessation. First, you have to answer if you provided screening on tobacco use, alcohol abuse, or illicit drugs, non-prescription medication abuse. If the patient screens yes to any 3 of those, then you will mark, and then the patient needs to be counseled on those that they screened positive for. If you don't screen the patient for all 3 of those, or if you screen the patient for all 3 and they came back positive and they were not counseled on what they were positive, you would mark no, the patient, you didn't meet the measure. If you screen the patient for all 3 and either they were screened and they were negative, or they were screened, something was positive, and you counseled appropriately, then you could code this as a yes. And we'll provide clarity in the training manual on this definition. And then we have the mortality date if the patient died after discharge, or if they were discharged to hospice. For patients who were discharged to hospice and who are still in hospice and haven't expired or haven't passed, my suggestion for coding these is to still mark this patient still in hospital alive, patient still in hospital until you have a mortality date. That way it will not screw up with your harvest when you go to submit those. Otherwise you'll be missing mortality dates, and it can cause you to have a missingness that isn't allowed. And then the final question is the status at 30 days after surgery, either discharged or in hospital. What was their status at 30 days? So I think that covers it. We got through the whole thing. We do have some. Go ahead.
Can I just, so this, remember this, discharge to hospice really is only going to count against your program if you have done a primary procedure for lung or esophageal cancer. And from that procedure, they did so poorly that they had to go to hospice. So that would be a very rare event should be for a primary esophageal or lung cancer, elective operation. Yeah, it doesn't matter if you're putting your tracheostomies in here or your peg tubes in here because you want to track it, and that person goes home to hospice, that's not going to count against you in any of the analyses that we do. It's really just the primary lung or esophageal cancer operation that the initial discharges to hospice is where that would act against the program.
Red, all clear. Code R red, all clear. Code R red.
Thank you, Dr. Wormuth. That's really helpful for the clarification on those cases. It is a very small number of patients, probably less than 0.5% from all the cases that we have. So thank you. Are you ready to go over to questions now, Dr. Wormuth? I think so. Okay.
Yep, I am.
We're going to go. Yeah, we have time. We have about 30 minutes. Are the tracheal resection post-op events also included in the post-op events section? Nancy, I think you're asking, maybe I'm misunderstanding. Are you asking that if your tracheal resections have a post-op event, are you still to capture them? And the answer is, yeah, you should still capture the post-op events in this section here.
Really shouldn't be a whole lot of overlap there. I guess one of the things she's saying is if she tells us there's a post-op problem in the tracheal resection, should she still say yes to post-op event?
Right.
Even if she's going to answer no to everything else.
Mm-hmm.
I know my answer to that, but it's probably not your answer to that.
We should still be collecting these post-op events are specific to the trachea, to the tracheal procedures, but we should still be collecting the post-op event section on those patients as well, just to have a completed form. Might be some double capturing, but hopefully not too much.
Yeah, I think the one obvious standout is the recurrent laryngeal nerve.
Mhm.
We ask it in both sections.
Yeah.
Slightly different question, but it's still the same idea. Yeah.
What does hernia reoperation not, why does hernia reoperation not include thoracoscopic and robotic options? Sorry for the scrolling, everybody. Do you understand the question, Dr. Wormuth?
My eyes are blurry from the scrolling.
Sorry, you got to close them when I start doing that. It says, why does hernia reoperation not include thoracoscopic and robotic options?
I'm looking for the question in our new form. Didn't we get rid of that?
Mm-hmm. I don't see it. Hernia repair.
Oh, the initial procedure.
Yep.
So it definitely doesn't have robotic. You know what? That's a good question. We didn't fully fill out the set.
Which one are we talking about here?
Yeah, right there, 3370. Surgical approach used during the initial procedure, and we don't have thoracoscopy, and so we'll have to fix that in 5.24.
Okay, add it to the list.
Good catch. Thank you.
Yeah, thanks, Nancy.
Yeah, where were you with left right 2 versions ago?
Aaron has a question here. He says that in version 2.41, the operative section, there was a question with planned staged procedure. We have moved that question just to the esophageal cancer section. He's saying that he used that question for the lung cancer cases that were staged. Now that that question is esophageal cancer, how are they to document staged lung cancer procedures?
I'm not sure. Is there an example of what the staged lung cancer procedure would be? It was kind of a controversial thing even for the esophagus, but we did it so they didn't have to fill out 2 forms.
Yeah, Aaron, if you could provide us with an example, that would be great. Thank you. In the post-op events, the question, did patient have another operation? Are these just unanticipated operations or all operations? Close your eyes, I'm going to scroll. I wish I had little bookmarks that I could just click on and it would take me to the section that I want it to go. Is this the patient have another operation through a new or existing incision? Is that to be considered for all procedures or only unplanned procedures? I'm scrolling through my notes.
I think the answer is unplanned.
And I think that's why we called it post-operative events in the post-operative events section.
Right. So the one time you would plan it is if you're doing like the esophageal. Some people do an ischemic preconditioning where they divide the blood vessels to the stomach one day and they come back the next day and actually 24 hours later put everything together, and they call that ischemic preconditioning, and that's sort of the staged esophageal procedure.
Thank you. Are these post-op events only during the index hospitalization or anytime during the 30 days post-op? So these are indicate all adverse events that occur within 30 days of surgery if discharged from the hospital, or those that occurred during the same admission regardless of the length of stay. That one I could answer.
So here, I've got a question for you. So you do an esophagectomy, patient goes home after say 7 days, they're home for 2 weeks, and they come back and they're still in the hospital with a readmission at the 30-day mark. We stop counting at 30 days, right?
That's 30 days of surgery.
Because they made it home, but they came back.
That's right.
Okay.
It's a tricky one. We had the same question in one of the other databases, and it's a tricky one where they got admitted great prior to that 30-day mark, but we only count the events that happen up to that 30-day. For post-op. Yes, so correct, Mary. If a patient is discharged and has a pleural effusion requiring intervention in the outpatient setting, that counts as a complication. And yes, that's correct. Status at hospital discharge, response DC to live, died after discharge. Does this replace the 30-day status? No, we still have the 30-day status down at the bottom. What happened to the quality measures antibiotic DVT prophylaxis? We're no longer capturing those. Do you have anything further to say? I know we didn't, we had some conversation about it. We decided not to capture them.
Yeah, I don't think anybody's using them. Since they moved to MIPS, I don't
Yeah.
think they apply anymore. They were there for what, PQRS? But that program isn't in effect anymore.
Yeah, and we're capturing the unplanned ICU readmission, unplanned ICU in the post-op section, and patient. So the task force decided to remove that. Another clarification, please, for the grades of post-op complications, pneumonia, ARDS, etc. Does the MD have to document the grade, or can the data manager use the STS definition and what's documented in the chart as answers? Same with leak and conduit necrosis.
I think if your chart documents it, you can code it off of that. We don't need any surgeon attestation.
Thank you. Will information on COVID diagnoses be included in version 5.2 when I don't see it? It will be added onto the data collection form. We just haven't added it in yet. And Aaron provided an example. He says lung cancer in different lobes and or sides, did a wedge on day 1 for one of the nodes, and then on day 3 would wedge or resect the other nodule. We would check that stage procedure, as we don't want to get dinged to unexpected return to the OR as it was expected and planned.
Yeah, that I wouldn't call that a staged procedure. Can you go scroll up to the operative section? I thought we.
Yes, sir. Close your eyes. There should be like a warning sign that comes up that, like, so people don't have to watch the scrolling.
Yeah, like a backup alarm, Carol scrolling alarm.
Yeah. Where would you like me to go here?
To the top of the procedures.
This one?
Yeah, even more.
Oh, multi-day operation.
No, so that's just if they go through midnight.
Yeah. Well, it isn't an unexpected return to the OR, right? So we wouldn't.
No, I would just think you do two,
Mhm.
particularly if you're doing 2 different sides, you would just do 2 different data collection forms, each considering it a primary operation.
Right. And Katie's saying that if it's a planned procedure, then it's not a post-op event. So it's not relevant.
Right.
So you just fill out the 2 DCFs and you wouldn't code it as a return to the OR. Okay. Well, that was easy. I guess we got through all of that and we did it way ahead of time. We had until May, I guess. Any other questions?
Can you just scroll to the bottom of the procedures?
Okay.
Nope. Then there you go.
I'm gonna go slow. I don't know what's worse, slow scrolling when you're ready to go, or if it's the section here.
Yeah, I just want to point out that this procedural laterality and then long esophageal, this block of questions is hides at the end of the long list that you probably all know. So you don't skip it. I don't think you really can, but.
Okay. It's kind of hidden there. If it is a planned procedure and it is not a post-op event, is the question to OR for procedure with general anesthesia, is that still applicable? Which question is that?
I think that's related to like the staging with the 2 nodules. So by planned, we really mean, yeah, we know there's a nodule on the left we're going to get on Thursday, and there's a nodule on the right and they're coming back Tuesday. Even if they don't go home, those would be 2 primary procedures. What we wouldn't want to consider planned was, yeah, now we're planning to do a tracheostomy on Thursday. That's still before the patient had their primary operation, they were not aware that they were going to need another procedure. That's kind of how I would think about the definition.
Thank you. Please repeat your discussion of mortality status and date of death. I'm not sure I don't remember what my discussion was, but.
I think you were talking about if there was a hospice discharge, but.
Oh yeah, I was just given a little tip that I think would help, probably help folks out on those patients that are discharged to hospice. I would still have that patient just for my own record keeping. What would probably help me out the most, it might not help you, but maybe it will, is I would keep those patients marked as patients still in hospital. Yes, until they were expired, until they passed away. And then I would code the rest of this. I would change this to no, marked discharged into hospice, and then I would provide the mortality date. The reason I would do that is because I believe general thoracic has a threshold for the mortality field. Is that right, Dr. Wormuth? Probably 2%. So yep. I would not want to get dinged for not having a mortality date filled out on this patient until I would make sure I actually had that date before I completed this discharge section.
And remember, this really is just, it was a primary lung cancer operation or a primary esophageal cancer operation, and things went so poorly that they're being discharged to hospice. This is not a malignant pleural effusion that you brought in for Pleurex's, who's now going home on hospice. You might tell us about that case. We're not going to analyze it. We're not going to count this against you. This really is, you did an elective lung cancer operation and it went so poorly that they went to hospice.
Yeah, that's a great point, because there are a lot of very sick patients that have procedures that are, that are more comfort procedures, and we're not looking to hurt anybody's outcomes because of those cases. It's the primary lung cancer and esophageal cancer cases that Dr. Wormuth is talking about. That's a good question. How many?
30. I can answer that one.
Okay.
So yes, the same for lobectomy.
Yeah, the question was how many esophagectomy cases are needed to be included in the star ratings, and Leanne says it's 30.
Mm-hmm. Yes, ma'am.
Yep, thank you.
And that's also documented in the report overview, and it's footnoted in your fall 2019 report, if you need a visual reference for other purposes.
Thank you.
Mm-hmm.
Discharged alive, died after discharge. How far along do we count deaths? But for it should be the 30 days post procedure. So, or up until the time of discharge if they're in the hospital past the 30-day mark. We did remove the other fields too, right? The 5-year follow-up fields.
Yes. Yes.
So that's kind of exciting.
Yeah.
What else did we do here?
I think the disposition and the NQ and the quality measures were the big things that we removed.
Yeah, the follow-up with quality.
And the big changes we added were the lymph node stations and piecing together the esophageal operations because the CPT codes are so out of date.
Yeah. Great.
Even though we want a CPT code if you have, well, we want a procedure name that's in the list. There's so many hybrid procedures now that we were asking for more details.
I hope there's lots of cheers going on about the 5-year follow-up. Joy says hi. Hi, Joy. Is there any word on the report being released in the March 5th submission that was postponed new due to date? Nope. Not at this time. Leanne, do you want to answer that one? I know you have a.
Yeah, I was just going to say, we do not have a current, a firm release date of that of those reports yet. We are working on it. The dashboards are built. So we are working to get that data available to you guys. We do realize, this delay is not ideal. So once we do have more information about a more specific timeline, obviously we will update you all as soon as possible. We'll send out an email notification. And also in regards to the harvest close date, we have not set that harvest close date yet because the surgeons and the task force wanted you all to be able to see your outcomes prior to closing this current harvest. So we will not set a harvest close date until we have those 2020 analysis results back to you and you're able to look at those. So once that happens, then we will set that the spring 2021 harvest close date.
Great, thank you. And I think we talked about this, but Dr. Wormuth, I'm going to throw this one your way. It says, does the 5-year follow-up only apply to new cases or will it apply to all old cases from years past as well?
I think if someone wants to give us the data, great. I think the likelihood that it gets used is pretty small, mainly because we've moved on to a very promising matching with the National Death Index so that we're trying to identify these patients and match them to the National Death Index without you guys having to do any legwork. So I would say it's pretty safe that you do not have to give us any further 5-year information. Even for someone that you've started it, you don't need to finish it.
That's what I thought I understood too, but I didn't want to give out the wrong. Okay.
Yeah, and Dr. Kozauer is in agreement along the same lines as Dr. Wormuth as well.
Okay, awesome. All right.
Yeah,
well,
just remember, it was his idea if you want to lynch somebody. Oops, I shouldn't have said that. If you want to talk to Benj, it was his idea.
Thank you. If the hospital does not submit social security number, will National Death Index still work? Yeah, they have a couple other fields that they can link to, but social security number is always the best one and the most accurate. But Dr. Wormuth, are you involved with the NDI linkage, and do you have more to add to that?
I'm not involved directly, but I know that there are enough unique data points that we can match probably 90 to 95% of the cases to the death record.
That's right. Awesome. That's good news. Thank you. Okay. Well, I guess if there's no more questions, thank you, Dr. Wormuth, so much for joining and helping us get to the end of this. Thanks for joining all of these calls and helping us get to the end of this review process. Thank you to Katie and Melissa for joining on the panelist side. And thank you to all the attendees for joining. Thank you, Leanne. I think we're good to go. So
I think so.
Unless anybody has anything else to add.
I don't know, just nothing that I know that you all and the core group, Carol and the core group are working hard to get the training manual complete and updated. So that is in progress and making vast improvements to that training manual. So we
I just want to say it's a lot of work. It's a lot of work. It's a lot more work than I was anticipating for those multi-select fields.
Mhm.
Dear Lord. But will you go over follow-up next call? No, we don't. We're no more follow-up. We're not doing follow-up, and we're not doing the quality measures, Debbie. So we're done here. Is there another question that you have about it? So yeah, the training manual is coming along as quickly as possible. Okay. All right.
We wrote down the on the GI procedures needing to add robotic and thoracoscopic, right? For
Yes.
3370.
I have that. Yes, sir.
Thank you.
Leanne will add it in the file for 2024.
Well, you have a list. All right.
By that time, who knows? Maybe the whole process will change. You never know. Let's hope not.
Yeah, it'll be on fire.
Maybe we'll see what we could do. Okay. When will physician documentation forms be made available? Well, that's a good question. I don't know that we've ever had those before, but it is something we talked about providing. Probably after the training manual is done, because that's quite a bit of work.
Yeah, we've never had those surgeon worksheets for thoracic or congenital.
So we'll be starting from scratch with those, and that's also quite a bit of work for both the core group and for STS staff. So probably after the training manual is available, we'll have those developed. And you're welcome to start working on those. And if anybody's on the call and they want to start working on physician forms, the surgeon worksheets, feel free to send us your ideas. Put some forms together and send them to us, and we can start with your form and use it as a template. So if you'd like. Okay. I think I'm going to stop sharing here, and I guess we're good to go, Leanne. Thank you so much, everybody. Thank you, IQVIA, for joining the call.
Thank you, everyone. Thank you, Carol. Thank you, Dr. Wormuth. Greatly appreciate it.
Yeah, thanks. Bye, guys.
Thanks. Bye-bye.